away from that, let's begin with the health-related issues. You are a special envoy, the UN, on issues pertaining to the HIV,
Yes.
free generation. Recently, there were cuts in the aids to finance HIV-related activities, especially in Uganda and other African countries. So, what is the status, according to you, who is in this field, and what hope do you bring or do you tell Ugandans today?
You know, it is the cost of delivery which is too high, the cost of delivery of care. Otherwise, the ARVs are not expensive. And the cost of ARVs per individual is affordable even by normal standards, even by the government of Uganda. But the cost of delivery of those ARVs and the cost of prevention, the plethora of organizations that go into purporting to work in the prevention area, the NGOs, the consultants, it is all a labor area. It is so, you can't believe it. If I'm to sit down and give you the details, because I did that. One of my papers was on HIV AIDS in Uganda and what happened from the beginning. So one of my doctoral thesis papers was about AIDS. So I also went into that. And now as a presidential advisor, I looked at it. And we sat in Mozambique as the champions for an HIV-free generation. And we found that 3/4 of the money in HIV is going to fuel, to lubricate the system that delivers. Now, when people know what it is all about and the cure is there, what remains again is down to the health system. What is the health system? It's not the hospitals. It is again the networks you set up in the community that will enable people know, I need to go for care. And there are other people like me, and they know what it is they need to do. Those we already have. So I keep telling people that even at Harvard, I did a course in the politics of pharmaceuticals and medical technology. This industry, the health industry, leave alone the one of herbal medicines, which is growing, but which is affordable by our people because they have the herbs. It is one of the most lucrative businesses. And if you are a health person, you are into the care of people who are suffering, you even get ashamed of being associated with the ministries and the health systems in countries that are recipients of so-called aid in the health sector. So even in HIV, that's what it is. Look at the health accounts in Uganda. They are there. We've analyzed, and you'll see that most of the money goes back. Consultancies, support to NGOs who are driving very expensive vehicles. The salaries are so high. But what is the cost of that ARV? And that is why the ministry has said, very good, let's integrate into the general health system. We won't have a parallel area for HIV, because what kills people with HIV is malaria. What is killing people with HIV is tuberculosis. What is all that? So really, what is happening is, to me, a good thing. To every cloud, there is a silver lining. And I've told the colleagues that this is a revolution. I've always said, short of a revolution in the health sector, will never change it. And this is now the time. We thought we would do it with HIV/AIDS. We failed. We came up with a system. We said, let the people own their health. Let the communities take charge. But that one does not put money in the pockets of the policy, the implementers, the technical people, the consultants. Then we got COVID, and it really showed us that really, without the Ministry of Health or doctors and whatever, people didn't go to the hospital. One would wait to see whether the death rates during the COVID were higher. But research shows that when doctors go on strike, people die less. You get fewer people dying. So these are things I must tell you. And because I'm a physician, I'm a surgeon, I worked there, and now I'm a social scientist. So I can look at everything going on. I can analyze data, and what I say is it is data which is collected by WBOS, collected by the World Bank, collected by the World Health Organization. It is sitting there. But when you analyze it to say, does the policy really address what this data is telling us? And I will tell you no. The policy and programs do not analyze what the data is telling us.
Is it the implementation or the policy on paper?
The policy is good.
The policy is good. But the implementation?
You see, if the implementation does not talk to the policy, then you have to ask, is the policy wrong or is the implementation wrong? And then you say, where? If it is the policy, you go back to the drawing board using the evidence, which is the data, the outcome of your implementation. So normally what we do, we have meetings which are addressing how many meetings we had, how many people we visited, but we don't look at the impact. So the indicators of success of the policy, if they are the same year in, year out, there is a man who said, if you do the same thing the same way and get
the same results,
then you are a fool to keep on doing it that way. Only a fool does that. So this is where we are now. So with HIV, we have all the evidence. It is not even when we didn't have the treatment, it is the communities that got involved in telling people what to do. Now, the pharmaceutical industries have come in. They are giving us the drugs. We have stopped talking. So there is a new generation which does not know anything about HIV. It is on paper. It is any virus. But the social networks are not at play just like they were when we didn't have the drugs. Because we are also saying treatment has prevention. But the most important thing is the best way to deal with any disease is not to get it. Not to get it. That is the best treatment.
Who slept on the job?
Who slept on a job? All of us. Because the more educated you get, the better you should be. You also have a responsibility to look for information, to look for knowledge. Now, people would say, oh, the government, everybody blames government. When government had one TV station, when government had one radio station, it was very easy for government to put all policies and whatever it wanted to do directly. When I was in government and spoke as a minister of women, every woman on a radio everywhere said, our minister. When I was vice president, I would say, this is the direction. For the youth councils, irrespective of what party, Suluru Moja, you enter. Now there is so too many radios, social networks, and research shows really that the people in the villages still listen to radios, but now they are local. So they look to local problems. You go to West Nile, where the HIV prevalence has always been very low, and people in the villages have not even seen somebody with it. So the radio stations, local ones, will focus on the local priorities. You go to Kalangala, where there are 4 women to 1 man. HIV is still a big problem there. I went there last year. We stayed for a week in Kalangala, looking at the community health system. And people came to me and said, Mama, AIDS is killing us. We know you have always been a champion. People are not talking anymore. So the communities, now the many radio, the media initiatives, the problem. They are not. It's now up to you who is responsible for ensuring the population gets the information, to get this community of media to come together. You identify the strengths and weaknesses of all these media stations, and you give them the information. Now, and you also listen to them, not only telling them this is it, this is it, because the media is a very important estate in the governance of the country. You have to give it more time. Now people talk about this WhatsApp, what is the proportion of the population? And when you go there, who is actually talking about health issues? They are not. They are talking about what they look like. And each one is focused on what is of their interest. So again, it is like a local radio station. Now politics is so popular because it's the most lucrative business. You invest in there, you earn a lot. Even if you are hopeless, you go there, you earn a lot of money. So it's really, so the health system, incidentally, even, you know, people think that the health system is about diseases. No. Health is your health in every way. So when you are a health expert, you have to have knowledge of all the elements that make a person well, socially, economically, physically, mentally. So you have to have an idea. And that is why when I went to get my doctorate, I didn't get a PhD. No. PhD is for professors. You start this way, then you go this way, then you go this way. So you should go to the university where you find other professors with the silos, then you teach the students, then each one comes out depending on who has impacted through what silo. But a doctorate teaches you how to solve problems of society. So this is the difference. And that's why you have to use evidence for policy. When you do that, you are able to say policy, the policy is very good. That's where we started. But the implementation is solving the problems of individuals who are in the health system. That's why you hear, pay us more as doctors. Pay scientists more. Who is a scientist? A scientist is a researcher, whether in the media, whether in the social sector, whether in agriculture. But you cannot go and regurgitate, control, copy, and put here, and you go and teach. You are doing no research, you've added no value, and you call yourself a scientist. So they pay you more.
Of recent, I've witnessed...
in the end, you know, the whole money, if you see how much of the budget of the Ministry of Health is to salaries, because they are scientists. you will be very shocked.
Mm.
So if they are scientists, why do we still have all these issues?
Mm.
Because science should identify a problem in the population or a need, and then you innovate to make sure you put an end to
Doctor,
that
don't
need.
you think it all goes back to priorities and coordination? Because you might have a coordinated health system, but when the priorities of government are also different.
Where is the health, what is the health system? And it shows if people define the health system, they will tell you that we have succeeded because we have now, we are turning health center 3s into, we are putting theaters there. So you see where the priorities are, just like you said. It's not the coordination. It's a wrong definition of a health system according to the implementers of the health system.
Mm.
It goes to where there is money being spent, you know. You build a hospital, that is a hotel. I can do surgery under a tree. I can examine your heart under a tray, this water container.
Mm.
In fact, that's where the Heart Institute is.
Mm.
So for me to diagnose that you have a heart, I don't need to have a beautiful structure. No, no, no. That's why when immunization does not take place in a hospital, when you go to immunize children, the children's ward will be empty. So the health system is all those structures, all those policies, all those institutions, all those actions, all those interventions go to support the wellness and well-being of an individual.
Mm.
So you are part of the health system. The farmer is part of the health system. Because if he's not taught that you should not put this kind of chemical on a cabbage, on tomatoes, and then you come, I see you liking to eat salad, you are you are just eating chemicals.
Mm.
Yes. That's the health system. How is food being manufactured? But who is really interested? One time I was told that people found glass in rice and sugar. And said we should investigate. Is it people doing sabotage at the point of sale, or is it in the factory? It should be a point of interest for the Ministry of Health, because food is the best medicine.
Mm.
That's what Hippocrates said. Hippocrates is the man, his oath is what we swear as we graduate. And he said, let thy food be thy medicine, and thy medicine thy food. So the health sector should be interested in the nutrition and how food is grown and produced for the population. So this is so the definition is wrong. So what we have is a ministry of diseases. We focus on diseases.
Isn't it a strange statement when you say what we have is a ministry of diseases?
Yes. Because look at the budget. It's budgeting for hospitals. It's budgeting for drugs. The interaction everywhere you go, it's disease, disease, disease. You look at the national health accounts, community health. If you use bars, you hardly see how much is going. At Health Center 3, which is supposed to engage with the population for their health. Health Center 3, go and look at the laboratories there. They look like cubicles. That is where you should go to test yourself for HIV, for TB, for everything. What is there? So this is what shows you, because if you want the community to be healthy, the diagnostic facilities should be at the lowest level where you have planned for the people to know whether they have something which is unhealthy.
So should I say that this is an organized form of stealing from the sick?
No, it is a functionally illiterate form of managing. You know, it is very interesting because I think I was also like that, because I was trained like that. I did public health. I did medical epidemiology. I didn't study social epidemiology. That's how I was trained. And I must say I was very interested in the medical epidemiology because it takes you to the village and say, oh, the latrine should be for you to actually deposit your feces so that you don't get cholera, you don't get dysentery. But now as a social epidemiologist, as a social scientist, I see the latrine in a very different way. I see the latrine as something which should not be deep there. I see it as connected to food production. Because as a farmer, I know the best fertilizer is pig dung, which is the same as the human dung. You put it in the garden, the bunches are like this. Now, so that's how we are trained. We were trained to identify disease and prescribe. And say, you need an X-ray, you need a CAT scan, you need this.
You need the CBC.
You need all those. But now the technology has even become so much, even the population believes that even the medical people, oh, for me, I've come for a scan. Musau, have you really found out what I'm suffering from? Because you put me in a scan for my stomach pain. I have pain here in my muscle, put me in a scan. Whereas when we were training, you take the patient to the relevant
specialist
diagnostic equipment according to what you have seen. We used to have, they say, differential diagnosis. What you suspect, number one. So please, that is the examination. What is, it could be this. So they go to the first one, it doesn't happen. Then, but most of the time, if you are well trained, the patient goes for an X-ray when you suspect a fracture. And you've examined and you see it's likely to be a fracture. And it is going to help you with the treatment. Otherwise now, CAT scan, scan, even for normal pregnancies, they want a scan to see whether the child is a boy or a girl. Before they would buy pink for the girl, blue for the... Now we all wear trousers, the boys wear pink. So what is the big deal?
Doctor, what contribution has the private facility helped in this way around to bridge this gap? Because looking at the cost of medication, hasn't this also spoiled everything, or there is some credit?
You know, the private facilities are there for people who cannot wait in the line. But now, when you go to a public facility, as you wait in the line, somebody is also telling you to pay. And the people who work in the private facilities are telling you that, you know, you will meet me in a clinic in such and such a place. Go for the treatment in such and such a clinic. I will investigate you in such a... So there is no public and private facilities in this country. Do you know? Because for me, my job is to give advice. And I visit both public and private facilities. I'll tell you, let's go to something which is of interest to everybody. There is no private hospital in this country with better facilities than the women's hospital in Mulago. None. There is even Aga Khan doesn't have it in Kenya. And yet Aga Khan is the top in Kenya. None. I have been there. I know what they have. I have been to Aga Khan in Kenya because Aga Khan, I've seen the rooms. If you want to feel like a president, you go and deliver in a presidential suite. But across the new Mulago Hospital, which is supposed to be the top referral, you should not get women who are normally delivering to go there. No, those they should even deliver at home with a midwife. Complications. So by the time you get there, the referral system is the one which puts you there. So there will be no line. And there will be no congestion. There are regional referral hospitals. Regional. There is one in Imbali. There is one in Jinja. Every traditional region, pre-independence, every tribal region, if I may say, has a referral hospital. So that is where people should go first. But because the human resource is now in disarray, they partly own those hospitals, but they also, now we've hyped their salaries. But still, they go to those ones, to the private ones, and get paid. So if issues of ethical conduct, not all of them do that. I know people who sit in Mulago. I know Dr. Nakwagala, an endocrinologist. He does not work in any private clinic. He's in Mulago there, in the general clinic, and the private clinic of Mulago. There's also a private clinic in New Mulago, but it's empty most of the time. When you ask them why, oh, you see, the payment is not well streamlined, whatever. So the management of the health system is also a problem. There is no referral system at all. People just go where they want. They go where they want.
Depending on their affordability.
Affordability. But you know, also, not all Ugandans end up there. 60%. If you look at the total population of Uganda, 60% do not go to public facilities. When you look at where people spend their money, or the national health accounts, the private sector is the one taking it all. When you look at where the money comes from, it's coming from the pockets of people, not even from these people where people are crying, what will people do? No. 75% of money for child care comes from people's pockets. 70% of money spent on maternal care comes from people's pockets. 65% of general care comes from people's pockets. The government has the majority of structures in the country. Yes. But the people will go there when they see the facilities are there. But when they open a new one and people talk about it, they will go there after some time. When these people now, the nurses, they go and work here. It's really, the ethics in my profession leaves a lot to be desired.
What could be the immediate interventions to this road?
Stop people from falling sick. People should refuse to fall sick.
How?
By doing things and investing in things that stop them from falling sick. Many things. Yes. Like for HIV/AIDS, don't just go sleeping far. If you have to wear a condom, the solutions are known. Hey, if you don't, you know that when you take alcohol, every woman looks very beautiful. So don't go there.
So, Doctor,
Yeah.
there is this.
So this is it. Most of the things are in our hands. Because the 75% of the diseases that affect our people and they need to go to hospital are preventable. That is where we should put a lot of effort. Then the hospitals will be empty. Then they will be closed, even the private ones. Look, for instance, I'll give you the sector of education. If the public schools were good, people would take their children there.
Yeah.
But now the people who are in government or public service, they are the ones who are teaching, who own the private schools. And the teachers, they are just moonlighting. And the public schools, you are told that they are not good. But where are the teachers coming from? The plethora of universities in this country, if you look at the per capita in terms of levels of professionalism, how many consultants, how many professors, how many PhD holders, how many masters, per capita students in these universities, we shouldn't have more than 4 universities in this country.
And yet more regions are
Everybody has
for
become a professor. Eh? Yeah. Everybody has become, because for you to be able to lecture, even at master's level, you are a teaching assistant. But here, people at master's level are teaching people who are doing their masters. Where are the people with the PhDs? Genuine PhDs, where are they? Because PhDs and doctorates teach you how to do research, so you are mentoring other people in areas that need research, and for masters, you have already identified these areas and you guide the students to do research in those areas. So they work with the teaching assistants who have already done research in the areas you've guided them. And then the doctoral person should have a number of people they are supervising to do their doctorates. And then in other universities, you are collaborating with others because of conflict of interest who are helping you. But here, you know, all these universities.
Doctor,
and the numbers alone are just very interesting.
coming back to...
So you go now even in education in Rwanda, where the system, the public schools are very good. Private schools have closed. There are only very few for those businessmen, whatever, but ordinary people.
It also comes back to the government medical facilities where people have been betrayed. They go to the health facilities, government facilities, but there are no drugs. And if the drugs are there,
the drugs are ending up in the private. So regulation is where we have failed, because the role of the center is the policy, strategic planning, resource mobilization, regulation, and M&E. M&E working with the centers of excellence. Not M&E that I'm now the commissioner, I'm the one to do M&E. A commissioner is a manager in a particular scientific area or a specialized area. You are not a researcher. Just because you had a master's and the up. A master's does not make you a researcher. No. So, regulation is where we have failed. So you find the regulatory bodies are sitting in the ministry in smaller cubicles. They are the small, and yet that is the biggest role of linking the center with the field. The professional bodies, the regulatory bodies that should go to make sure they examine, they do whatever they need to do at professional level, facility level. Otherwise, it will make you cry. The equipment is there in many of these hospitals, but sometimes you find doctors who are posted there cannot even do the surgery. They cannot do the procedures because of the training. There is nobody to mentor them. You get 40 interns in a hospital in a particular discipline, 30 or 20 on a ward. How will they be mentored? So even regulating according to the number of people you can train to full completion. So each university should be told this is the maximum number that the government will absorb within the facilities. You train more, you know where you'll take them. Maybe you take them to Kenya or DRC or Sudan, but and now also one thinking that because I trained in the new liberal environment in the education system, that the government must make me an intern and pay me as an intern. No, the people that government pays for, you get a scholarship to go and do medicine. As government, I will pay for your internship. But you went as a private student. Let the person who took you there pay for your internship. That is the logical thing. Otherwise, if I didn't pay for you, why should you put me in a corner? You are not in my plans because these universities are private. We are training for the whole world. We are not training for Uganda only. So people failing to articulate in good time what should happen.
Is the problem paying the medical interns, or the problem is the amount being paid?
Well, no. Even the fact that even if you pay them 10 million and you have it, where will they go to do their internship effectively? So it starts from the beginning. So government should be very clear. These are the centers where internship can be done. And these are the professors who will supervise these interns.
The SHOs.
Senior SHOs are doing their masters. They are called the senior house officers. Yes. When they finish, they become associate consultants or associate professors. Then they super specialize in it. Yes. The SHOs are also students. Being under every ward has professors in specific areas of expertise. And under there, they are master's students studying. So these supervise the interns, and they also, as they train, they are also training others under the supervision of a consultant or a professor. Now tell me, you really, people's lives are in grave danger. You go to somebody, they take out a phone when they are operating. It's very dangerous because we are not regulating. Otherwise, the policies are wonderful. That is now clinical care, but minimal attention to population health and preventive care. Except for immunization, we've done a wonderful job. Also because immunizable diseases are the ones which are the domain of the center. The center is responsible for epidemics. So within its job, it has done very well for controlling epidemics, preventing epidemics, managing epidemics. That one, the ministry, I give it accolades. I really say bravo. But when it comes to regulation, they are trying to go right to the village, taking nets directly from the center to the sub-county. That is a public health issue under local government. But local government as a ministry does not have a department of community health. The community health is in the Ministry of Health. It should be there. Health education. The people are not at the center. Just do policy. Then that department, implementation is local government for prevention. All public health.
Doctor, do you take time to advise these people?
I do. My job is to advise. I don't have the mandate to implement. That's not my mandate.
I get you.
Yes.
You were in government. How was the system that time?
20, how many years ago? 23 years ago. We were planning. The two ministries that refused to be restructured were the Ministry of Health and the Ministry of Education. I chaired the restructuring of government, but those ministries were getting a lot of money from donors. So the donors dictated, for me, I will give you money for malaria. So there is a malaria control program. I will give you money for AIDS. So there is a department, AIDS control program. I will give you money for jiggers. So there is a unit handling jiggers. This is how that ministry has been.
In fact, of recent, when there is any outbreak and it is being announced, what goes through the minds of the public is now we are about to hear about supplementaries. Supplementary budget, we need a supplementary budget to cater for this and that.
Yes, at the center. But when you go to really, the solution is to empower households and communities to own their health. Then those who fall through the sieve, cancer, even diabetes can be managed at community level. The complications are the ones which should go to the hospitals. Otherwise, even giving birth, only 10% of women who are pregnant need to give birth in a hospital. 10%. And then those ones will now be managed by the SHOs. When they go to Iganga Hospital or the regional referral hospital. But to come to Mulago here, those are the complications of complications that should come to Mulago. Yes. Most Ugandans are healthy. My father has never been admitted in any hospital. He's still alive.
Oh, he just doesn't tell you.
How can he not tell me? I just look at him and know whether he's okay or not. Hey. Yes. If it wasn't for the accident, the disc prolapse, a surgical problem, and the fact that I had twins, which is a complicated pregnancy, I would have been delivered by a midwife. Most Ugandans don't go to hospital. do away with malaria, make sure there is nutrition and sanitation, and Ugandans will sleep under the mango tree, they will walk naked, they will just do their own thing. They will not need to go to a hospital. Yes. I told you when the government came in 86, 87, 88, 89, and we mobilized for immunization against measles and the polio, the wards became empty. There were no, the children's wards became empty. As we who were surgeons now, for the first time, we started seeing children's surgical cases. So it was deemed necessary to start training pediatric surgeons. The wards were empty, and one of them was turned into a pediatric surgical ward. There's 75% of diseases are preventable. Yes. And number one is malaria on the list. If the status quo remains, what is the future of our health systems or health of Ugandans? You know, the health system will cease to be there. The people will do their own thing, like they've been doing. You find people selling drugs on the street. So many drug shops everywhere. You find everybody is a doctor. Anybody can operate on anyone. Chaos. Yes. Because the health system is not only the government or public facilities. It should be, like I said, all institutions, all actions, all inputs that go into promoting health are part of the health system. So wherever it is, wherever you are part of the health system. So if things are going wrong there, the health system will not go right. Yes. When I happen to visit some countries, these modern countries, I found out that there are specific medicines that can be got over the counter. And there are some medicine that you have to get with a prescription from a doctor. But talking about these emerging drug shops and private clinics. Even here by law, that's how it is. By law. That's how it is. On paper. If you have no pharmacist in that place, there are drugs which you cannot get. So first, who is in that drug shop? The drug shop should be off-the-counter medicines. Panadol, like now these anti-malarials, which are also being abused. Because the village health team is really like a drug shop. But drug shops, you must be a nurse or midwife or somebody. But to be a village health team, so long as you can talk and say, oh, you have fever, now we've treated. They are not medically trained, many of them. So it's just chaotic. Again, regulation. It's there under the law. Even the pharmacies. The pharmacies are like stalls in the market. Tomato, in the market. Pharmacy here, pharmacy there. The law does not allow a pharmacy to be established within a particular distance of another one. Then you can regulate. Then you can know that the people who are working there or who have opened that pharmacy will be able to break even and keep the business going. But you put a pharmacy here and a pharmacy there, and the money is exchanging hands. This we know. We have very beautiful laws. Very. Don't we have even a big institution fighting corruption? But it continues. There are very many. Yes, that's why I said you asked for the solution. People should rebel. They should demonstrate by not falling sick, by doing things so that Because very soon the drug shops, because the biggest thing is anti-malaria. It's the biggest, but now even...
And of late you have infections.
They will tell you you have malaria, you have brucellosis, you have typhoid, 3 in 1. So they will give you anti-malaria, they will give you antibiotic for, this is for brucella, now this is for typhoid. That is really ethically. They will tell you, you know, sit there, they take off your blood, they go behind, they come with something, a stamp that the lab is saying this, you go behind there is no laboratory. There is even no microscope, nothing. So the solution is don't fall sick.
Is the problem or an overwhelming population?
What overwhelming population? The bigger the population, the better for you. Because then information moves much faster. Yes. That is how it is. With the IT, information moves faster. Regulation. Those who are doing it wrong should be brought to book. Your clinic is doing wrong things, close it. And take those people to book. File with the police immediately. You know, now I have a diploma in law. So you give me medicine which is not, I'm not okay. People think that doctors are gods, really. But now we are going to be obsolete, because one can go on the phone, Google, and ask a question, and they will tell you. Many people have an idea. But even if they come and you are told, do this, they just look at them and go away. People know. We are just, we are just there. I don't know what to say. Because by law, everybody can be sued for negligence. Whether it's for serving food in a restaurant and I get diarrhea and it shows it's food poisoning, that restaurant should be closed and I am compensated through the legal mechanism, through mediation or whatever. But nobody does that because people fear to say I have diarrhea. Otherwise, you get a whole 50% of people attending a wedding in a hotel, they get diarrhea. Then others, these MPs who are eating right and left, that people are poisoning them. No, it is rotten food which you are eating, full of bacteria. You go to a clinic. That is why now, in the health sector, after being at the Law Development Center for those 9 months and in court for 3 months, I can see the existing lawyers cannot ably sue people in the medical sector because they don't know what questions to put to them. And that is why I even also recommended to the Law Reform Commission and the Judicial Service Commission, I said, when I went there with my group, which were studying and giving them feedback, we say, just recommend people to become lawyers after specializing in a particular course. Yes. Otherwise, what is in law? They are doing the history, which I did as a population health expert. The culture, the laws they are talking about are the laws in family law, which are gotten from our culture and then religion. Yes. Otherwise, it is very difficult for you to question me as a surgeon, and you come out with a way that will put me to book. Why? Because even everybody around that operating table, it's a club. They will not be witnesses. No. They will not. It's like a club. So if you get doctors going to do law and they go to work with justice, we may see some sense in this. You get a laboratory technician or technologist going to do law. I can tell you with all the confidence that if you manage to get a medicine degree, you can very ably get a degree in law. Because even our training, the way we interrogate people before coming to a diagnosis, you are already tuned into that. Yeah? So finish your degree, finish your internship, go and do law, and you'll bathe in money. Suing these hospitals and and drug shops and whatever. So that is a lacuna that we have at the moment. I know there is a lady who was doing law, and I think she has finished now. I forget her name, because when I was in the Law Development Center, they told me that already there is somebody who is doing law. Because since I went to the ministry in 2011, I've been talking about it. You do journalism, go and do law. Or you've done something else, go and do journalism or communication. Then you become an expert in that area.
So, Doctor, of recent, there is an ongoing initiative of malaria vaccination. What is this all about, and what information are Ugandans missing or should know about malaria vaccination? You have been in the Busoga region, and we can have a quite good survey from that area in regards to this initiative.
Now, again, the politics of pharmaceuticals and medical technology. Malaria is a very old disease. There are only 2 parts of the world where there was no malaria at one time. Only 2. That is Greenland and Tibet. Because the mosquitoes, the larvae which need water, there was never water there. It was either ice or snow. So they couldn't reproduce. Now, even the way those people dress, where would the girls bite you? They are just like this because of the cold. So since my training on malaria, I knew that malaria bites inside the house. So the remedy is to come and drench the walls inside the house with an insecticide, and after the mosquito has bitten you, it goes and rests there, and within 3 days it will be dead. So you reduce the number of bites of the mosquito, which is likely infected, the female one, for it to go and bite another person. When I went to Harvard, I did a full semester course on the history of diseases in the world. And the 2 issues which I discussed with my sponsor, my president, were either HIV/AIDS or malaria. On examination, I was going now into the anthropology of sex when it came to HIV, and there was no professor who was an expert on sex and anthropology. So I opted to do malaria, which was also a global issue, and countries got rid of it one by one, and Africa was remaining. Now, Northern Africa, Egypt recently was declared malaria-free, and yet it has swamps around. They also had terrible incidents of malaria at one time. Algeria, Tunisia, now it is sub-Saharan Africa. And I started this global fund, giving us medicines. What is the politics of it? Because I also did a course full semester course on the politics of pharmaceuticals and medical technology.
Mm.
And I found that people are not interested in getting rid of malaria in Africa.
Mm.
The records showed that, because the London School of Tropical Medicine was started specifically to look at the issues of malaria in the colonies. In the colonies. When World War came, because they had their own contingent, you know, armies in Malaysia, in Asia there, for them the problem is not like here. They used the DDT and got rid of it. Even in Europe, they used the DDT and got rid of it. In Africa, the governor of Ghana wrote back to the parliament, they are there in the archives, and said in sub-Saharan Africa, we don't need to bother. It's part of their culture. They have their medicines, and you know, they dance around it. You know how malaria gives you fits and convulsions and whatever. They paint themselves, and now that is not a problem. So
then for the case of Uganda?
The case of Uganda, a research was done in Kigezi, currently now Kinkizi, that area, where they were moving people for other reasons, and they sprayed the area where they were moving these people from to, so there were no mosquitoes. So an economic study was done of people who were from those areas, and I went and got the populations, what age they would be across our census. That study also shows that those who were children, after spraying the mosquitoes and settling people and treating them, meaning denuding them, removing malaria from their blood, those people are the current Bachiga you see. Bachiga, you know Bachiga of my generation. They are the Ruhakana Rugundas. They are the Runumis. Many of them, their education, they did so well. And when you get that cohort, compare them with the cohorts of Basoga, of Baganda, you find that they are much richer than them. Now, the policy has been reduce malaria, not get rid of malaria. So wherever you go, from when I was a child, we sleep under net. The nets are still there. They focus on pregnant women, because certainly with the anemia, you get malaria as a woman, you get a problem. And the women die from bleeding. Why? Because they are anemic, they get pregnant, they are anemic, the children inside are sucking them. So they start on this prophylaxis. When you are pregnant, they give you antimalarials and folic acid to help you replenish the blood. Now, they give you a net, and they give the children nets. Other people don't have nets. Even if the mosquito bites inside the house, the nets are on a bed, the people are eating. The mosquitoes are biting them. Now, going back as a social scientist now, people then, immediately it becomes dark, they run into the house. They are wild animals, there is no light. But now, The sociology of mosquitoes has to be looked at. In Sri Lanka, they found that mosquitoes bite more in houses where there are lights and where people are sitting where there are lights. No longer this business of, it's really incredible because we are stuck in the 1900s now. So, the strategy has been to reduce malaria. Now we've also come in with a vaccine, which is also targeting children, where you go 6 months, the mother, you take your child. 7 months, you take her to the clinic. 8 months, you take her to the clinic. 1.5 years, you take them back. Now we find that even now, pregnant women, they may go once to antenatal. Going back when they are feeling okay, they won't. Why are they targeting children? Because they are the ones who are dying more. So this is also a reduction strategy. It is not to eliminate or end malaria. So we've been talking about this. Our president has been categorical. How do we end malaria? So during COVID, he said, tell me, how do we end malaria? I chaired a Zoom meeting during COVID on that subject. It was an international meeting with the professors from all over. So they said, we all agreed, the problem with malaria is not a lack of knowledge as to what we can do, but it's a governance issue. It is a policy issue. It is a funding issue. Otherwise, the technology, the science of malaria is only changed in the way of the sociology of malaria because the way people live has also changed and technology has changed the way people live and behave. So I decided to go to Busoga. You know, many people do not relate health to the economy. We just, oh, somebody is sick, it is a humanitarian, it is my human right. No, people don't budget that way. What do I gain out of it? If I invest in malaria as opposed to investing in somebody growing obutunda. We don't know that the people who are growing obutunda will not be productive. Yet NDP is talking about the human resource and its productivity. So I go to Busoga. The children do very badly. We are working with Makerere University, School of Public Health, or College of Public Health. You know, the names are changing all the time. With the Busoga Health Forum, which was started, a volunteer organization started by professors from Makerere. I'm an advisor. So I say, yes, you can go and mobilize money to get incubators for children born very early. But I said malaria is a big cause. So they accepted to work with me on malaria in Busoga. So for 2 years, I have been in Busoga, mobilizing all communities, religious, professional, technical, business, from across Busoga, getting data from each of the sub-counties of Busoga. The data you see here that it is 40-something, no. In sub-counties next to the water, like now and where we are going to pilot, we are actually piloting now, you find that when you go to the health center 3, page after page, everybody going there is malaria. Malaria, malaria. The village health teams, out of 10 of them, they are walking, treating children with malaria, thinking they are okay. They are positive for falciparum malaria. So, we have said that we know the science. We have the technical people. The government commits to treating every Ugandan with malaria. and it is saying get tested first. But what about the mosquito? Always the mosquito, they give donation. Recently they sprayed in West Nile. Somebody lobbied and they got DDT. Of course the names are different. So for us, we did our own research. We are all volunteers, technical, and those who are not. But mainly I'm working with the social scientists. Why? Because there's a missing element in the management of malaria. When we bring the nets, we take them directly to the sub-county, ask the LOCs to distribute them. And recently ants were out. So they put them to catch ants. Even now, you find them. So what we are doing now is to mobilize the communities to make sure we sustain the program. So when it comes to malaria, I said enough of reduction. Because that means you are just keeping a granary of the infective agent. Multiple granaries just moving around the country, working. You go to the banks, what is the reason why people do not work? Malaria. What is the reason for school absenteeism for the children? Malaria. Teachers, malaria. Inside the house, at home, how many, is there any of you who takes 3 months without getting malaria? Any member of your family getting malaria? They keep down. How many do? They all put up their hands. And they say, mama, no, not only once. We get malaria 2-3 times the same person in the year. We get malaria, you go for treatment, you come back, you are not better. You go back, they tell you you have malaria, and yet you've been treated. So we explain the science. If you have malaria, there are people with immunity, so they will not show they are sick. They will have no fever. So even the data we get from the clinics is the people with the complications of malaria. So people are walking around with the malaria parasite. We are the incubators. So we agreed with all the technical people in Usoga, the DHOs. We sat. The biostatisticians who are looking at the data, the clinical or health center 3 people who meet those complications before they go to hospital, they all said, Mama, if we are to really work to do something about this region, let us start with malaria. Then they say, I say, you know, have you heard about PDM? They know about the money. They don't know about the other pillars of PDM. They don't know that pillar 4 is talking about health and education. So Busoga, the children, they are doing very badly. The Busoga are the poorest. Busoga is an island. It has so much water. Mosquitoes are everywhere. The sugarcane now has even made it worse. The village health teams, 80% of them are moving around treating people. They have malaria because we've tested as well. So we agreed. Without government support for the 2 years of mobilization, we have been able, the people of Busoga, to say we are coming up with a Busoga malaria eradication program. Let the ministry remain with the reduction. Bagumaza abantu. So we said we are going to do it. Nobody is paid per diem or a day allowance when they come for meeting. These are technical people. Nobody is asking for per diem if the meetings end late. So my job has been to feed them. And the Busoga Health Forum, which is a volunteer organization of everybody, not medical people only, they have been the secretariat. We are working with the government structures. We are working with local government, district government, and we've been able to get the malaria control program to give us 2 experts in spraying and treatment. These are Dr. Roy, Erina Liendiera Viro Luisi, and then Dr. Navakoza. So people ask, you cannot maybe eliminate some. Our first impact is the ministry now saying we are going to not to be called a malaria reduction something. Now we are going to do elimination. They say you can't eradicate. I say that's our vision. If you don't know where you want to go, you will want to stop here and stop there. It's not possible. What about the one who removes a mountain starts with 1 stone at a time. The one who is to go on any long journey, you start with 1 step at a time. So we have now put together our malaria eradication program. The first thing we talk about is not this issue of what? Treatment. No. We are saying mobilizing the community. So we are working with the LCs, the women leaders, the youth leaders, persons with disability, religious leaders, and we with them, they themselves, as a community, on each village, they have identified 10 change agents, and we've called them health brigades. Because we know after malaria, these are the ones who are going to remain there. We are giving them training to remain as health brigades. And these are religious, the religious leaders and the cultural leaders, even the Wasamize, they are part of it. So they are the ones we've sat with. The pilot is going to be in our Ningi sub-county, where we found almost 85% of the population is positive for malaria. 85%.
How long do you want to achieve the vision or the results?
You know, it's all about organization and the fear of the traditional malaria experts. How will you sustain it? So the community, we've mobilized the community to start a sub-county investment forum. This forum is of people who live in that sub-county, those who are outside the sub-county, who were born there, those who are married there, those who work there and have money to put on a side to invest into the well-being of the people and also come up with infrastructure which will be used for the development and growth of the sub-county. So we got the chairman, Ndaye Yakub, chairman, LC3. He brought us a list of 25 eminent people from that sub-county. And when we met, they said, this is wonderful. We've been looking for ways to participate, and we didn't have it. When people die, it is malaria. We are the ones who have to buy the coffin. The politicians said, our MP, Muuma, Honorable Muuma, Milton, he said, Mama, let me tell you, every week, vambikira abantu 20 people, malaria. So now they have formed a wellness association, registered with community development in Iganga district, local government, they have got an account with the Stanbic. Stanbic has said in the region they will support all the wellness associations at sub-county level. And already from when we started 2 years ago, my pension is the one which has been feeding everybody. This association, the first time they sat, they said 11 million was already put on the table. And we have been training the village health brigades, working with the DHO's office, the officer responsible for environment and WASH is the one who under the DHO's office. We have a labor officer who is our communications expert. We use Rusoga, not Ruzungu. Within 3 days, he can teach you in Rusoga. He has never been to medical school or health, whatever. He's been able to understand.
So should we take that region as a demonstration area?
Well, they say they will. Now, on Sunday, we are showing them the budget. Within 1 day, we are going to map all the homesteads, the households, the institutions within that sub-county, within 1 day. And the teams are from there. They have formed them themselves. 2 people, each village, 4 teams of 2 people to map the village in 1 day. They said, we are tired of this, Mama. Listen, remember in the census, I sat in my home, nobody came. We want it done in 1 day. And they are volunteering. Then, after mapping, we go and spray inside and outside the house. Bishop Naimane of Busoga Diocese, when they were sitting here with over 200 reverends, they said, Mama, let us tell you, as you sit there eating ensiri, even when you are having tea, in the evening, the parishioners have come, the ensiri, ekusandagira kubalaza. So we are going to spray inside the house, not to drench the walls. No. We are going to spray under, like we've been taught how to spray for mosquitoes, outside the shrubs. We are mobilizing the village health brigades, and now mobilizing for cleaning the compounds, clearing the bushes. Then we spray. As we spray, within 1 day, we want to have finished almost the 10,000 households in that sub-county. Then we start with the teams of village health teams and local leaders, 10 of them sweeping from each village, 10 teams testing. If we find somebody with malaria in your home, we treat every member. If we find nobody, we move on. If we find there is somebody in that household who has had malaria or is on treatment for malaria, we treat them because we know there is a lot of reinfection. And the test we use is just for falciparum malaria, the one which is malignant. We call it, it's like a cancer. It eats you everywhere.
So finally, you said that you're working on a no budget, and you've prepared a budget for the ministry.
The ministry, what we want from the ministry and the central government is actually the testing kits and the drugs. That is their mandate. Everybody you find, anybody test and treat. So the government will give us that. And just one sweep like that, the government will spend over 500 million. But to really spray and test and treat, we need 80 million. And I'll tell you already, schools have started saying, please. So I have already submitted to the First Lady and the President. I have briefed them I'm a presidential advisor on population and health, and said really, for less than 1,000 shillings per person, we should be able to spray. Already the drugs are here. And after that, you will not be able to say we need money for Usoga. No. Because I did economics as well. I said where malaria, countries with malaria, when they actually get rid of it, within 1 year, their growth rate jumps by 3% within a year. So people are more productive. Children are going to school. I'll tell you about Vutiki Secondary School. Busoga
That is Kira College.
Yeah, Kira College, Vutiki. They asked to work with us. We didn't spray. Just treatment as Busoga Health Forum. We found 45% of the children reported on day one with malaria. So they were all treated. And now, since this term started, the nurse is redundant. There is no sick child. So we are going to work with the schools as surveillance centers. And already the head teachers, everybody, the money is in the budgets. So for us to sustain it, we've said we are not going to wait for government. If the president can actually give us some 300 million, we should be able to do greater Busoga, greater Iganga, spraying, and he treats. We also need a donation to do that, so that we speed up the exercise. So these investment forums are the ones which will now follow up surveillance in the schools within that sub-county. And anybody found with malaria, we now go and spray and treat. So that within the next 3 years, by the grace of God, if we are supported to do the mobilization as a catalyst, Busoga Health Forum has positioned itself as the catalyst and coordinator between government and the communities to speed up implementation of government programs. Because that's what the president said, let's get rid of malaria. But this vaccination, according to the results in other countries, its impact is not different. So, the parasites will be there.
Okay, thank you very much, Doctor. Just because of time, we didn't dwell into the political field, but I hope next time.
This is all politics also. This is politics of the technical people.
I understand.
Because they are the ones who are supposed to do this, and we are the technical people. We can talk about that also some other time.
Some other time. Thank you very much for the information.
Because now people are positioning themselves, and as we mobilize, they are saying, Mama, this time we are not taking mediocres to parliament. You do something. And I'm beginning to see young people who are ready to really serve the people. Because we have no mechanism for identifying them. But when you, like now under these sub-county development forums, you are going now to have you see people who want to give back and serve the people. They come in with ideas and you say, this time let us take an hour and maybe give him 2 terms. Next we go to Vulamaji, give that one or her 2 terms. Like that. But now there is no basis. What do the people want and what are they doing as a community?
Okay, thank you very much, Doctor. And please have a nice time. Nalongo. Think any word for the wise?
The ball is in your own court. Because omusoga akoba atya omwigo gwegala tigukuyitira musota. Like now we've been waiting for donors to come and kill our snakes here. Let's come together as neighbors as a community to really hit these snakes, malaria, TB, and whatever that are within our compounds and homestays.
Okay. Thank you very much, and God bless you.
God bless you too. Yes.